Well, welcome everyone. It is 5:02, so I think we can begin tonight's presentation. Vivian, if you want to advance the slide. So thank you for joining us tonight and welcome to our webinar. I am Wendy Gulden. I'm an endodontist and I'm medical affairs for Sohn Endo. Tonight, let's review a little bit about tonight's webinar and our objections. We will be covering the review on why being behind running a gentle wave cycle on all appropriate teeth in the mouth and what is the benefit to the patient. We're going to look at and discuss platform building technique between molar versus anterior teeth. We will also emphasize the unique anatomy of anterior and premolar teeth and why these straightforward cases are usually never just so straightforward. The webinar does include 1 CE credit, so let's quickly review that process. So 1, you must be registered. Attendance will be recorded via Zoom. We're going to send you a survey in an email. We ask that you complete that, and once that's completed, we will send you the CE certificate via email. Along the way, if you have any questions, please reach out to me or education@sohnendo.com. So tonight is a very interactive session and your questions are welcomed and encouraged. There's going to be a dedicated Q&A after the presentation. Along the way, please enter any of your questions in the chat box, or you may come off mute and ask the question during the Q&A session. And Karen said you can also ask it during the presentation if during a certain slide you have something that seems very significant you want her to cover again. So it is my pleasure to introduce you tonight to Dr. Karen Potter. Karen was born and raised in San Clemente. She opened up her private practice here in 2010. She graduated from the University of Iowa. Karen is married with 3 very energetic children and is a long-term gentle wave user who has completed almost over 3,000 gentle wave cases. So I'll turn it over to you, Karen.
Thank you, Wendy. Let me get my screen shared with you all. And a thumbs up, we can see everything. Good. All right, so I always find this webinar type format just awkward and like the new times where we're just talking to a camera and I only get to see a couple people's faces. But I do want to just reemphasize what Wendy said, that I really do want this to be interactive. So if you have questions, I'm here to just kind of share my wealth of knowledge. I'm happy to clarify anything or even, go in a different direction. If you have a question that's about gentle wave that's not really covered, as long as we can cover it in the time we have together. And then you can also always reach out to me separately by email or my Instagram. I'm happy to try to share everything I know. So our topic tonight, when gentle wave, when Sohn Endo asked me what I wanted to talk about, I knew immediately what I thought would be a good idea, because a lot of times when I'm on peer-to-peer calls, or if Wendy emails me or calls me about a doctor who's having trouble, it's related to the use of gentle wave on anteriors and premolars. And molars, super straightforward. We see lots of presentations about it. We take a course about it. It's very obvious where the access opening is. Stick your PI right on top. But with anteriors, it's a little bit more tricky, and there's a little more technique involved. So I told Chris, I want to talk about why we should use this on every case, not just molars, but also anteriors and premolars. And so, like Wendy said, we're going to talk a little bit about why we should run it on every tooth. And we're going to talk about platform build and the technique differentials between the molar and anteriors and premolars, and some of the troubleshooting that you might have on those cases that get you frustrated and maybe have you consider just doing a traditional case of endo. And then we're going to talk about unique anatomy of these teeth and why even straightforward, quote unquote, cases are not always so straightforward. I always find it interesting when general dentists tell me that they only do the easy root canals, and I laugh in my head. Out of respect to them, I don't laugh out loud, but I always think there is no such thing. And so we're going to try to emphasize that tonight. Obviously, this is my disclaimer slide. I am a KOL for Sonendo. I have been for some time, and I don't do it because they pay me the big bucks. I do it because I'm very passionate about this, and I think talking to me one-on-one, you can feel that and sense that. And so even though I am being paid to be here tonight, these are my opinions. I'll be brutally honest, the good, the bad, the ugly. I've been through thousands of cases, so I've seen a lot. And this is coming from my heart. So Wendy gave me a little bio. I'm just down the street from Sonendo headquarters. I went to USC, UCLA, and University of Iowa. Now all in the Big Ten. So I get to go to a lot of games now. And I've done research, been published many times, and I love to teach. So when I got out of my endo residency, I quickly realized that root canals are hard. You know, we learned from these Hess teeth years and decades ago that this is what our goal is, to disinfect this. And that's very challenging. And I acknowledge that our goal as an endodontist is to try to heal apical periodontitis through removing inflamed tissue and bacterial biofilm and contaminated root materials from this kind of complex anatomy. And it's not easy. You know, we had to get all this crap out of our teeth. We had to get the bugs. We had to get the silver points, the cotton pellets that were in there for 20 years, the posts, the pus, all of it, the thermophil carriers. It's our job to get it all out. And we had to do whatever we had to do to achieve that. And sometimes it required opening up a tooth really large, trying to get the irrigants down with a needle. Other times it involved calcium hydroxide medication, you know, maybe leaving it for weeks to months. And, you know, we had to kind of use our best judgment call on when we've done enough. And the more time I would spend in these teeth, I would feel better about myself and sleep better at night, knowing I did my best. And sometimes if I did it in a single visit, I would question myself later that day. Or if the patient called with a flare-up, I would question myself. And, you know, it was always a judgment call. And then, you know, the day came where I grew my family and my priorities started to change and everything shifted in my life. And before this, my office was my baby and my cases were my little lovies. And I had always had such a tremendous job satisfaction because I loved what I did and I felt like I did it well and with compassion and care to my patients. And then, you know, these little humans showed up, and I found that I would struggle to balance my time with work and my cases and my babies, my real babies, human babies. So, you know, I practiced a long time with this way of practicing and medicating certain cases and spending a certain amount of bleach time in the tooth. And then the day came where I had to consider trying to maybe create some more efficiency in my practice and giving me some more peace of mind because I couldn't just always focus on the teeth. So in about 2018, I was reviewing my vision statement that I had written the day I placed my letter of intent to buy my business. That day I didn't even own the practice yet. And I wrote a letter of intent, a vision statement of what I really felt like I wanted my business to encompass. And one of the things as I was reviewing this was that I was advocating for the latest technology available to be part of my business. And I had incorporated Cone Beam, early adopter of that in 2009, before I even owned a practice. And, you know, all the other technology that we've had for a long time. But after some soul searching, I knew in my heart that I really wasn't using the best technology available, which I had written, you know, 8 years earlier, that was my vision. And so I pulled the trigger on this amazing and phenomenal technology that, originally when I was first introduced to, I felt like was too good to be true. Because, usually when something seems that way, it usually is too good to be true. But after researching it and after talking to respected colleagues who used the technology, I knew that I thought it was the most efficient and effective way to do a root canal. And so I pulled the trigger. And at that time, after I had researched it, I knew I wasn't just going to dip my foot in. I wasn't just going to test the waters. I wasn't going to just, use it on necrotic molars or super complex retreatments. I was convinced that this was really the best irrigation technique available. And I thought it was the future of endodontics. And so at that moment in time, I knew that I wasn't just going to cherry pick my cases. I was going to do this 100% across the board. And from that day on, I've done a gentle wave procedure on nearly 100% of my cases for over 5 years. So we all know how it works because I think we're all users on this call. And so I'm not going to go over all of it because that's a whole different course. But the one thing that I am going to touch on is degassing. And in my opinion, it is the degassing mechanism that sets this technology apart from all others, from passive ultrasonic irrigation, from laser, from endovac, from endoactivator. All of these activation techniques, we still have vapor lock, and we still can't really clean the apical third. And so the degassing mechanism is what truly helps us disinfect the entirety of the canal. And we all know how effective this technology is in molar endo. It's amazing. It's second to none. And I mean, this technology is just really showcased in molars because we have such complex anatomy with these multi-root and multi-canal teeth. We see it time and time again. We see it all over social media. We see it on the AAE, whatever exchange. And there's just no better way to clean a molar efficiently. But what about single-rooted, a premolar or an anterior, okay? We can do this case in 20 minutes. It's burdensome to build a platform. It's burdensome to run an 8-minute irrigation cycle on a single rooted, straightforward case that we tout. We already have a 97 fill in the blank % success. Okay, yeah, we all can throw out success percentages that are great. It's because what we do is we're really good at it. But, why would I take the time to build a platform and do a root canal on this tooth? Well, because not always do we know that there's complexities involved. Maybe there's a bifurcation that goes just to complete opposite sides of the tooth. And we can't expect to adequately clean this type of anatomy when it's hidden and with, just a needle and a file. Even if you can get your file down one of those, you probably can't consistently get it down both. And you sure as heck can't get an irrigation needle down there. And so it's anatomy like this that actually causes persistent apical periodontitis and symptoms. And this is a post-op, a terrible crown margin, but that's not what we're looking at. We're not judging our sad restorative doctors' work, but we're just judging this treatment of apical periodontitis and how even a straightforward, easy case can actually not be so easy after all. Or what about this straightforward single canaled premolar with a moderate curvature? Okay, why bother with this gentle wave when our success rate is so high in this single rooted tooth? Well, because sometimes there's a little bifurcation and a little loop in the apex, and without activating the fluids and degassing the fluids with gentle wave, we can't clean that apical third. How could we possibly get an irrigation needle past that curvature in that conservative canal shape? It's just not possible. Or what about this? Slam dunk. You see a number 9 on your schedule. You see it that it's wide open. It's not calcified. It's already basically been accessed. So what about an easy case like this? Well, how straightforward? Why would I waste time building a platform and running a gentle wave cycle on a simple case like this? Well, this is why, because we have multiple portals, and without, trying to degas and to activate that fluid, we will not necessarily clean all of this space. And the GentleWave doesn't discriminate between canal space. It cleans everything it touches. So what's holding you back? I don't want to spend the time and energy or inconvenience to build a platform for a straightforward case. Okay? No, platform builds. Oh my gosh, they are so laborious and tedious. I hope you sense the sarcasm, because it's not true. My goal in tonight's presentation is to make it so easy and predictable for you to build a platform on an anterior or a premolar tooth, so that you don't even consider it a hindrance in choosing to grab that PI for all your cases. Okay, I'm going to demonstrate the fundamentals of a platform build and show you multiple cases that are considered easy, where the case is more than initially meets the eye. Okay, so cases where I'm really glad I grabbed that PI and ran a GentleWave cycle. So let's talk about platform builds. All right, well, in a perfect world, it's going haywire here. Okay, in a perfect world, all of our teeth would have 4 walls, right? We'd access a perfect little hole through the occlusal of every tooth, but that is not reality. Okay, we all know that in reality we have crowns, and we have broken down teeth, and we have resorption cases, and we have caries, and we have all sorts of fractured cusps. And so these are more likely the teeth that we're seeing each day. And this is my team that helps me in the trenches. I have 3 wonderful women that work for me, and they help me do my job well every day. And this is me when my platform leaks, okay? Because we all know that when the platform leaks, it's just a time sucker. We have to either fix it or jump ship and start over, okay? And it took a long time for me to master a platform build, and I do feel like now it is very predictable and very easy. And with a few basic principles that we're going to review today, we're going to make it so that you feel the same, okay? And it's going to cut down on your time. So, number 1 principle, good isolation. The reason good isolation is so important is that our goal is to keep the root disinfected and keep the bleach out of the patient's mouth, all right? My whole goal is to run a GentleWave cycle, and it starts with rubber dam. Okay, so we'll go through rubber dam techniques and how that can be easy for you. Because sometimes with the GentleWave, you need to make sure that that bow of the rubber dam or the wings are not anywhere near your sound seal, potentially dislodging your platform. We want to make sure we have a dry field. Dry, dry, dry. We want excellent hemostasis. We want to follow our ABCs of platform building, which I will review with you tonight. And then we want to start the case with the GentleWave procedure in mind. Okay, what does that mean? Well, to me, that means that my number 1 goal for every case I treat is that 8-minute irrigation cycle. So when I open up the cone beam, before I even meet the patient, I'm immediately reading it, not just from a diagnostic standpoint, but also a planning standpoint for how am I going to treat this case to achieve a successful GentleWave cycle, okay? And we're going to talk about how we can do that on every case. So there's lots of ways to skin a cat, but rubber dam isolation, it took me a lot of trial and error to figure out what worked for me, because I don't want my rubber dam anywhere near my platform building material, my sound seal. And so there's lots of ways you can do it. And I know I've talked to a lot of my GentleWave colleagues, and we all do it a little bit differently. But my 2 most common clamps are this 2A, which is a premolar clamp, and this anterior clamp, okay? And so since we're talking about premolars and anteriors today, pretty much exclusively, I'm going to use one of these 2 clamps. So I like to do a split dam most of the time. Molar, premolar, even anterior, I love a split dam. What does this mean? It means I clamp the distal tooth and the mesial tooth, and the tooth I'm working on is smack in the middle, and I have full access to it, remove caries, remove restorations. I don't have to worry about my sound seal being anywhere near my rubber dam clamps. And if you look on your upper left, you'll see that my tooth is clamped, and I use a wedgette to help secure it in place on the mesial. If you look in the middle, you'll see I'm using an anterior clamp. And if you look on the right, you'll see 2 rubber dam clamps, both premolar clamps, isolating distal and mesial abutments. So lots of ways to do it, but the most common way that I do it is the split dam with 2 rubber dam clamps. So let's watch a little video. Okay. So we're going to clamp the premolar, second premolar. Clamping second premolar. And you're gonna hear clicking here. You're gonna isolate so that 3 teeth are visible. Pull it to the mesial and clamp the mesial. And then place the anterior-most clamp. Now we have 3 teeth exposed. The tooth in the middle is the one that we're going to be treating today. That is my split dam technique for, I would say, 95% of my cases. Molar, premolar, anterior, is split dam with 2 rubber dam clamps. So once I have rubber dam isolation, I like to try in my matrix to make sure before I even touch the tooth with a burr. I like to try in my matrix in my ideal positioning so that I can make sure that I have a draw with the matrix that is not being impinged upon by any bow of the rubber dam. So this is particularly important with an anterior clamp that may be a little cattywampus. Like once you put it on, if it's not like completely straight, if it's a little bit angled, you might discover that you don't have a draw with your matrix. It's also really important if you're clamping a second molar and you're working on a second molar. So you're working on the tooth that you're actually clamping, because if that bow kind of tilts forward, you may not be able to seat your matrix entirely. So if you're not getting a draw before you even touch the tooth, it's probably best to adjust your rubber dam clamp so that you can start with success in mind. You don't want to be all the way through a platform build and realize you can't take your matrix off because your rubber dam clamp is in the way. So the next thing we do, come on, is caries removal. Okay, you cannot bond a sound seal to a carious tooth structure. Okay, so caries needs to be removed. If you don't remove it, your platform will fail and you'll have to start over. So remove it right off the bat. And then also a lot of times when we remove caries, we have bleeding because inflamed gum tissue. We want perfect hemostasis because also blood cells will not allow bonding of sound seal to tooth structures. So I usually use like Viscostat. I try to get as much drying as I can. Sometimes I use like my System B. I crank it up and I just cauterize the tissue, or an electrosurge to cauterize the tissue and get it nice and dry. Now, a lot of times we're working subgingivally. So in those instances, I like to use my Cavit hot dog, is what I call it. I say, Leah, can I get a Cavit hot dog, please? And she knows exactly what I'm talking about. And it's essentially this little wiener of Cavit that goes perfectly interproximally. And I can take a moist cotton pellet and tamp it in place over any of the tissue. The tissue could be not bleeding, but seeping or even a little moist. And this is a perfect kind of matrix for moisture control. So I use this anytime I'm working on a tooth that had interproximal decay. I have my Cavit hot dog. I tamp it down with a moist cotton, and I use a spoon excavator to scrape away any Cavit that might be on my dentin, because I really want to maximize my surface area of dentin to sound seal so that it's caries free, it's dry, no blood, because any bleeding gum tissue is now covered with an moisture impermeable barrier that is the Cavit. All right. So we got rid of our decay, we got rid of our blood. Now we have to start building our platform. And we're going to talk about our Sound Seal ABCs. And, you know, the Sound Seal ABCs are alcohol. We need to have a perfectly dry field. Bonding agent, if needed, and I'll go over why that might be needed sometimes. And cure incrementally. Okay? So ABC, alcohol, bonding agent, cure incrementally. And so let's talk about alcohol. When we use alcohol, we have to desiccate the dentin. We should get the whole area wet with alcohol and then air dry with high-speed evac right next to it so any moisture can be sucked away. And if your rubber dam isolation is perfect, which it should be, then you will have a dry and desiccated two structure. This is the kind of two structure that we want when we build a platform, because Sound Seal actually has a really decent bonding kind of retention to dentin and enamel. But yet it's easy to flip off when you're done because it's not, you know, that chemical bond is not deep. It's not a deep etched and bonded bond. So it's a great material, but it needs a dry field. So we always want to use alcohol and then desiccate the two structure, nice and frosty. And then B is bonding agent. Now this is like an insurance policy. If you have a really broken down tooth and you don't have a lot of retention form, you know, I like to use the embrasures to kind of flow my Sound Seal into just for a little extra retention form. If you don't have embrasures, maybe the tooth's really broken down. Sometimes I do bonding agent. It just makes the Sound Seal a little stickier so that when I build my platform, I don't have as much chance that that platform's going to dislodge. And then C, cure incrementally. We have to remember that Sound Seal is a light cured material. So we do need to cure incrementally in a couple millimeter segments. If you put 5 or 6 millimeters down, you're not going to get a bond. You're just not going to, that deepest layer is going to wash out. It's not going to be sealed. So this is every time we add a little bit, we cure, and eventually we place our matrix on there and we seed it and we cure it again. And now we have our beautiful matrix that's on the tooth, and we can take a little explorer to break the seal, so to speak, and then take off our matrix and cure occlusally. So it's a multi-curing step process. So if you have a really slow curing light, I would encourage you to go buy a woodpecker. It's worth it. 3-second increments, and it works great. So let's talk about some anterior modifications, because with a molar, it's very easy to know where to seat the matrix. You have a hole, you squish it down onto the hole, okay? But on an anterior tooth, the matrix actually seats at the long axis of the tooth, not perpendicular to the axis opening. So what does that mean? Okay, what it means is this would be perpendicular to the axis opening, and this is not how we seat the matrix, okay? We instead seat it perpendicular with the long axis of the tooth, okay? So we build the cingulum up, so we have essentially like a fake occlusal table at the long axis of the tooth, and then we seat the matrix directly down against that artificial occlusal table. Okay, so let's watch what we mean by that. And I think this video is 2 minutes, so bear with me, it's sped up, but it's still 2 minutes. Okay, so what we're doing first is our ABCs. We're alcohol drying this tooth, and we're gonna have my wonderful Leah hold her high-speed evac there so we can get all the tooth structure dry. You see I use Aura Seal to help any area that I don't have a perfect seal. I close that up and I caulk it. And then I'm going to slowly in increments. Now I skipped the B because I felt like I had a very good amount of retention form here. So I skipped bonding agent, but I'm going to cure incrementally. And look, I'm building up that cingulum because that is the artificial occlusal table that I'm building, okay? I'm not trying to stick my matrix deep into that axis. I'm just trying to seat the matrix at the long axis of the tooth. And so every time I add a little bit, and now you can see I'm doing 8 and 9 here. So I ran 2 gentle wave cycles on this tooth, but the base of the platform I'm building as one unit, and then I'm going to do 2 individual matrix placements, but we're only going to watch one of them on this video. So you can see I'm building up the cingulum incrementally. I'm constantly making sure under my scope that I have straight line access into my canal, because, you know, the gentle wave needs to have fluid into the canal. That's the only requirement. It needs to have the fluid be able to get there. And I'm trying in my matrix to make sure I can seat it on that occlusal. And I'm going to load my matrix with Sound Seal. And then I'm going to seat it at the long axis of the tooth. My wonderful Leah is going to cure this 3 seconds on each line angle to make sure that the entire bulk of the platform, because again, light cure material has to be cured with a light. So I'm going to use my Explorer to break the seal and gently, and then remove one last. I'm looking there to make sure that I have straight line access to my apex. I can see my canal, and we're done. We're ready to ride the wave. So now we have 8 minutes of fun and a successful root canal and a happy patient. So I just want to re-emphasize this, okay? You do not need to place the tip of the matrix inside the access cavity, okay? This comes up a lot on peer-to-peer calls, especially with minimal prep docs. You know, they criticize the gentle wave. Oh, I have to access too large for this procedure, okay? You don't have to actually access the canals any size for this, except large enough to just have the tip of the matrix approximate the access opening. Okay, so there's no need to open this access wide. You know, what about small accesses? Okay, look how it's just seating. It's just making, it's basically maintaining the space of the access. It's blocking out the Sound Seal from going in. Okay, and then riding the wave. Okay. You don't need to seat it inside. It just needs to block the space. What if your access is even a little smaller than the tip of the matrix? Well, there's lots of ways that you can block out your canal and then build your Sound Seal up big enough so that all you need is access to fluid to go into the canal. So we're going to borrow a beautiful video from my wonderful friend, Dr. Missoura. And I was going to try to fast forward this. For some reason on my screen at this moment, it's not letting me fast forward it. But I wanted to show that he is, let's see, not going to let me fast forward tonight. So you can see he's doing the same technique that I just did. The part I was really wanting to show you was that he has such a small access that he is going to use a space maintainer in the canal to block the canal out so it doesn't get Sound Seal in it. And you can see he's building up his cingulum. He's got his woodpecker. It's looking good. And he uses a gutta percha cone right here. I use the tip of a microcannula. I stick it in there. I build up the Sound Seal around it. Look, you can see he's using the gutta percha to just block his space. Gonna light cure it, make it nice and hard. The reason I use the microcannula is that the gutta percha sometimes with the heat of curing can get soft, but it isn't always the case. You know, he's able to pull this out quite nicely, but the microcannula obviously doesn't get soft, so I could just pull it out no matter what. And then he pulls it out, and then I want to show you how he's going to take a football diamond burr and essentially re-access and make kind of reopen that space so that he can seat his matrix down deeper. Now there's a direct communication between the top of the platform and the root, and he's going to place his matrix right there and then cure it. And now, even though his access was teeny, teeny, tiny, he's able to run a gentle wave. All right. So it's that easy, okay? We now know how to predictably build a platform, even in the most conservative of apical of preps, okay? Access preparations on anteriors and premolars. So now that we can do that and we don't have any excuses, let's show some cases that may have been perceived as easy, but aren't necessarily that easy, and why in the end we're always glad we picked up that PI. So we're in the final stretch. We're gonna do some cases, exemplifying like why I use the gentle wave on all teeth, not just hard teeth or necrotic molars, etc. So let's talk about this canine. I bet you guys can guess how long this canine was, give or take. It was about 31 millimeters. And there's no type of activation, no ultrasonic tip, no endo activator, no endovac, no laser that can get down 31 millimeters. So gentle wave is the only way that we can really predictably clean this. And you know, I used to probably medicate this. I couldn't even get my calcium hydroxide to the apical third, let alone my bleach. But now with gentle wave, we very predictably can clean this and even get that lateral canal and see some beautiful healing. And I can do this in one visit and send the patient away and not have to worry about, did I do enough? Am I going to lose sleep over it? Is it going to fail? Am I going to have to do surgery? All of those things that we used to worry about.
Hi, Dr. Barter. We have a question.
Yes.
How do you build the platforms on the two central incisors without blocking out the access on the other tooth?
Are you talking about my video that I showed? So you do block out the access,
Yes.
and then all you have to do is take like a little diamond wheel or any burr you choose and just cut back you run the first gentle wave, you cut back the platform a little bit, and then you stick the matrix on your second tooth, and then you run the second gentle wave. You do block it out, especially if it's the anterior mandible. But all you have to do is just shave off a little bit of the platform and then rebuild the second half of the platform on that second tooth.
Okay, thank you.
All right. Okay, so here's another case that at first glance looks really straightforward, you know, but obviously we take CBCTs now. So let's look at the CBCT, and we see a little trifurcation. So in this case, you know, there's just no way to physically instrument that. And so I rely on chemical debridement with the gentle wave. So, you know, we've got a really nice example of not having to worry, not having to medicate this case. I mean, if this were vital and you left tissue in there, you know, you're looking at a lesion in a couple years. Hopefully we don't have that problem this time around, because we know that we have gotten chemical patency on all of these portals of exit, not mechanical, but chemical. So the gentle waves just cleaned all of that tissue out. Here's another case, super straightforward. You know, there was some decay, so we took the crown off because I always remove decay, and like want to make sure that I have a really good solid vacuum and sound and platform build. So took off the crown. I never could get an apex locator on this tooth. I hit a brick wall, and in the past I would have spent a long time pre-bending files and trying to get a file down to the PDL. And I don't do that anymore. I trust the GentleWave to clean that out. I probably would have medicated this case in the past because it had a big lesion and I just couldn't get patency. But with GentleWave, this is why we didn't get patency, because we had like 5 portals of exit. So, you know, yeah, maybe eventually I would have gotten one little pre-bent 6 file down one of those little ramifications, but could I predictably cleaned all of those in an alternative method? No. So here's our healing. Beautiful. There's the reestablishment of the buccal cortical plate and regrowth of that apical bone. Very happy patient, happy doctor. And another case, let's talk about this canine that had a beautifully intact cingulum and then a cervical decay. And I don't want to drill through that cingulum. I'm going to do a buccal access on this tooth. Okay. Well, some would say, well, you can't do that with the GentleWave. Au contraire, you can, because all I have to do is use my fundamentals and my basic principles of platform building. And instead of building up a cingulum so that I can seat my matrix, I'm building up a buccal cingulum. Okay. So was able to, and this was back in the days of the APM. So that's why this platform looks a little different, but was able to run my GentleWave, and there is a clinical photo of my gutta percha, and there's my final product. Let's talk about this case, because this case used to give me nightmares, and you know, it still kind of does because it's really gnarly. And going into it, you just know that there's multiple canals and there's a branch, lingual branch. And so going in, you already know kind of where to look. You try to pre-bend, you try to get down. I never could get down the lingual canal. And, you know, in the past, I would have medicated this, I would have prayed. And now I run the GentleWave and I do my best to obturate it. And this is my obturation. And I did a squirt technique on the lingual. So I could actually, in this canal, I could actually see where the canal was branching off, but I just physically couldn't get in it. And I didn't want to compromise my coronal tooth structure to try to get a file in there. So I just trusted the GentleWave to do what it does. And sure enough, this is a 1-year recall. And if you want to see cone beam, because that's what the truth holds, there's your cone beam. We have beautiful apical bone, lateral bone, everything. Looks great. Very happy. Asymptomatic patient. Here's a case that I got the recall recently. This was a case that 20 years ago, they had noticed discoloration. They tried to do a root canal. They couldn't do the root canal, too calcified. So they bleached it and then placed a composite. And she came back with symptoms and a lesion 20 years later. So we knew this had a big lesion. We knew it had a very calcified canal. And I knew that I was going to do this in a single visit. So I accessed, I found the canal, I instrumented very conservatively to a 15. And this is our 2-year recall. We have intact lamina dura and apical bone. We have, yeah, there's that rarefication there, but it's bony trabeculation. Inside there, patient's asymptomatic, and we're very, very happy. So single visit, I would have never done that in the past. Another case that came in recently, again, single canal, but we're obviously looking for lateral anatomy. Yeah, I could have gotten a file in there maybe, and maybe medicated it. And here's the CBCT, but we don't do that anymore. We do GentleWave. So there's my final product, and here's our recall. And we always want to look at the cone beam to check all the bone. Looks great. What about this case? I hear from people, oh, I don't want to use it on resorption. Well, there are some resorptions you can't use the GentleWave. If the resorption is blunderbuss and exposed a large surface area to the sulcus, then obviously no. But if it's a pinpoint portal of entry and it's below the attachment, I routinely use GentleWave on cases, molars and anteriors and premolars. So here's a case that we had a lingual cervical resorption, and we decided we wanted to try to save the tooth. So we ran the GentleWave. the GentleWave will kill clastic cells just as it will kill pulp tissue, okay? It just disinfects and sucks everything out. So we get a lot of really cool sealer in those spaces without mechanically boring out teeth. We're just conservatively cleaning out those clasts, okay? And yeah, little sealer, lovely long sealer puff here. But you know what? 2 years later, the patient is still doing great and asymptomatic and no loss of bone or attachment on the lingual without surgical resorption repair. So it's possible. You have to choose your cases selectively, but cases like this are very possible. And there are many of us around the country with GentleWave doing these. Very conservatively, I might add. 2-year recall. Here's a case of removal of an old thermophil. You know, you always kind of wonder vertical root fracture, potentially. It's not. It's a lateral canal and beautiful healing. Love seeing this kind of stuff. And then one more case, just to basically review a case that with apical resorption that I would have 100% medicated in the past. 100%. Okay, 2 visits, make sure I cleaned that kind of convex area there. But with GentleWave, I feel confident it's clean and I fill it and I get recalls. This is 3 years and I knew I could clean the tooth. So why would I medicate when I know I can clean the tooth? So let's do some takeaways. Running a GentleWave cycle is worth it on all teeth, including anteriors and premolars, regardless of perceived easy anatomy, okay? There's always more in there, and I'm never disappointed I grabbed the PI. Intricate anatomy cannot always be seen on a pre-op CBCT. I showed you several cases that looked kind of straightforward to begin with, but had complex apical anatomy or lateral anatomy. The platform build should not be a deterrent from running a GentleWave cycle. If you're having trouble with your platform builds, I want you to review the principles that I've shown you today, or come into someone's office and watch us work. We can predictably build a platform, even on the teeniest, tiniest mandibular anterior tooth, just using the basic principles. The matrix does not need to seat deep into the access for the GentleWave procedure to work. Again, you just need to block the canal out and then build your platform out around the tooth structure and then seat your matrix directly on that. It's like you're building an artificial occlusal table. And then don't hesitate to grab the PI for all dentition, because even though, yes, you could do it in 20 or 30 minutes, does that mean you should? No, it means you should do it properly and do the best service for your patients, and they'll benefit in the long run. So, root canals are fun. Yes, they are. We go to work every day. We love what we do. And now I'd like to open it up for any questions that you might have or any just discussion.
I have a few, Karen. That some of these cases are just so outstanding. The resorption case, tell me what sealer you used on that and how you obturated that.
So I use BC High Flow exclusively. And the way that I fill that is a technique that Scott Hetz has taught me, which is and Michael Ribera, which is basically filling. First of all, I obturate the main part of the canal to below the resorption, and then I fill the remaining space with high flow, BC High Flow, and then I take heated gutta percha and fill the space. Now in a molar, because my access cavity is large enough, I take a cotton pellet and I spray it with endo ice and I shove it into the access cavity. So I'm simultaneously freezing the gutta percha. So it's basically a plugger, and I'm squishing the sealer into those spaces, though it's just hydrodynamics. So it just squishes the sealer. Now in an anterior, you can't do that. So I wait for it to cool, and then I at least cool enough that I feel like I can use it as a plugger, and I condense apically, and it squishes that sealer into those spaces. And then I remove that gutta percha, or at least what I need to remove, coronal of my CHA, and then I restore.
Okay, great. We have another question from Maria. Do you take a CBCT for each endo? And also, in the cases of open apices, is it safe to use GentleWave? Is there no risk of hypo going past the apex?
So the first question was, do I take a CBCT on all cases? And the answer is yes. I do not put a handpiece to a tooth without three-dimensional imaging. So if the patient comes to my office having had a CBCT previously that is current and that is diagnostic to me, I don't take another one. But if they have no imaging, I take one on every single patient for diagnosis and treatment planning. And I use it throughout the procedure as a guide as well.
Open apices, is there a ruler that you use where you maybe not use GentleWave? How do you handle those?
I mean, obviously we have to use our best clinical judgment, but I have, and according to Sonendo, an open apex is a contraindication for GentleWave. Now, I like to teach that there's a difference between relative contraindications and absolute contraindications, okay? So an absolute contraindication is, for example, using nitrous oxide on a pregnant woman, okay? There is no court of law that you could sit on the stand and justify that as a practitioner. That is an absolute contraindication. But a lot of the Sonendo contraindications for GentleWave are based in like a CYA, cover your ass type contraindication. They just haven't done enough research on it to say that it's safe. So they say, oh, it's contraindication. Well, to me, that's a relative contraindication, okay? So that to me means that I can use my clinical judgment and treat a case the way that I want to treat it. And if I can justify it in a court of law based on using my noggin, then I'm going to be okay. So in the circumstance of open apices, I have learned enough about the physics of the mechanism of action of the GentleWave that I feel very confident using a GentleWave in an open apex case. And no, I don't measure or do any sort of rulers. I know people that have used it in revascularization cases, like wide open. And it's the physics of it that are way over my head, and I'm not like a physicist, so I don't know all of it like by heart. But the bottom line is that it's a negative pressure device. It's sucking out more, it's not pushing anything in. So if you have straight line access to the PI and evacuation and nothing's blocking, you should have no worry of a sodium hypochlorite accident.
Awesome.
Maybe Wendy, you can even extrapolate on that further if needed.
Yes, let's ask, Stephen has a question, and he came off video, which we appreciate.
Can you hear me?
Hi, Steve.
Can you hear me okay?
Yeah.
Oh, good. Yeah. Hey, Karen.
Hey.
Hope your family's having a good summer.
Yeah, that's my buddy from San Clemente, guys.
Yeah. Good to see you. Yeah. Thank you. I enjoyed the lecture. So when I'm doing, I was thinking about your platform design on the anterior tooth and how that can be a little tricky. I think it was a little easier with the old anterior platform for me than it is with the bigger clean flow, but I'm getting used to it. It's just another, change. You got to just figure out the little tricks, but this helped a lot. It sounded like you think that it really matters the direction that it's going. And I don't know if that's what you were trying to convey, but this is a feeling, I don't really know, is it doesn't have to be, because, once you get that GentleWave going, it's getting into all the nooks and crannies, whatever direction it's going, whether it's horizontal or, vertical or whatever. So as long as I see that it goes into the canal, I feel that it's pretty good. It's working. Does it make any difference to you what direction the platform's going at to get the solutions in there?
That's a great question. And the reason that I emphasized long axis is that a lot of doctors feel that they can't seat they don't understand that they don't need to seat the pin inside the access to get what they need to get done. It's actually better to be just essentially more of a straight line. But yes, it's still going to have mechanism of action if it's slightly off kilter. It's just that we don't want it to be at an angle like this. We want it to be kind of going along the canal.
Okay, I understand, and you did make that point, and I understand that. Okay, yeah.
I mean, if it's like this versus this versus this versus but it's just not supposed to be facing the facial surface of the tooth.
Right.
You know, you're accessing from the lingual. You don't want it just shooting straight at the facial surface. You want it to really penetrate deeply down the canal, especially on like those canines that are so long. You just want to maximize the mechanism of action, and the angle helps with that.
Yeah. Okay. Yeah, thanks.
Karen, going back to that resorption cases, how do you control hemorrhage after gentle wave?
You would be surprised. So I feel like in resorption, so much of the bleeding is because we still have cells that are so inflamed and bleeding, like the resorptive cells, like on a routine case. But after gentle wave, it's shocking because you clean so much of it out that you really don't have a lot of bleeding, at least in my experience. I had one resorption case that I had a hard time with hemostasis, and I purely just walked away. And I came back. I was like, I told my assistant, just when you see the red, just suck it out. Like when the red comes up out of the access, just suck it out. And then I did some charts and I came back and I was able to get it. But in hindsight, that resorption that specific case was, I believe, too advanced for what I was attempting to do. It was probably like a Hithers 4 versus like a 2 to 3, which again, you practice and you live and learn. Like we're all learning every day. I'm not claiming to be some expert that doesn't need to learn. I sit through gentle wave lectures and learn from my colleagues all the time. So, these cases are about selection and conservative. They need to have a pinpoint portal of entry. If it's a blunderbuss portal of entry, this is not your technique. That's going to need a surgical repair. It's the pinpoints that are size 2 to 3, not advanced 3 to 4. And I know the Patel classification is much more involved, but I'm just kind of trying to make this easy to understand that of how I go about my thinking process. So I'm not going to do this. I'm not going to save every resorptive case I see. Like half of them or more, either I do nothing or I recommend extraction. These cases, and I've done several of them, are very case selective.
And if you do repair, what do you repair with? And then do you have them back and do gentle wave after that, after it's set up?
So I will repair with Gerastor, or I will refer to the periodontist, and I will restore the tooth like to the level of the resorption or even apical to that. And then they will go in and they will do the repair with Gerastor. I'm very selective about where I will surgerize for these resorption repairs. And if it's beyond my cup of tea, I will refer to perio because they're much more capable of working with that tissue than I am. And I know my limits.
Great. We had a case about your sealer. Again, just to confirm, you only use high flow BC sealer. Is that right? Mm-hmm. And do you ever find it washes out?
I have had a case come back recently that did wash out a little bit in the apex. I was like, oh, that's interesting. But lack of apical pathosis and it's all clean. So again, it's not what you put in, it's what you take out. And I haven't seen failures come back that have had washout. I've seen washout on routine recalls, but they're not failing.
Okay. In terms of maxillary molars where the roots are close to the sinus, let's talk about that. Or if they're in the sinus, do you still use Gentle Wave, and how do you file a little differently?
Yes, I still use Gentle Wave. I use Gentle Wave on all of my cases. I don't remember the last case I didn't use Gentle Wave. So this is where when I say that I start the case with a Gentle Wave in mind, I literally start the case at the minute I open the cone beam. I've not even met the patient. I open the cone beam and I'm analyzing what I see, and I'm already recognizing challenges or issues that may come up that are going to hinder my ability to do that 8-minute cycle. So I will look and see where the sinus is. I'll look and see where the root apices are, if there's mucosal thickening in the sinus, if the sinus is crystal clear, all of those things I'm going to take into consideration, but I will still run a Gentle Wave. So the only thing I will do is maybe just instrument a little shorter, and maybe not, if I'm using my apex locator, I'm maybe not going to where it's red. I'm going to like where it just beeps solid, and I haven't gone to the red yet. And that'll be kind of my estimated working length. And, if I see that I missed the mark on my gutta percha film, I might go back in with like a little hand file even after the Gentle Wave and just make room for my gutta percha. But the Gentle Wave isn't going to extrude. It doesn't do that. And this is the same topic as the open apices. It doesn't extrude. It's negative pressure. It sucks back out. So it's not, the only time I've had issues with the maxillary sinus is when I go too far with my hand file and I've gone into the sinus. It's my fault. It's not the Gentle Wave, and I just lose suction because now I don't have a vacuum. So I don't worry about the sinus. I just alter my technique by maybe just being a little hair more conservative in my instrumentation and my IPEX locator.
And is that the same for the mandibular canal and the mental foramen things?
The mandibular canal and mental foramen I'm more worried about my sealer. So I don't care if sealer goes into obviously I don't want it to be like in the sinus, but like if it goes in the sinus, I'm not going to be like losing sleep over it. But if I get sealer in my canal, my mandibular canal, yeah, I'm going to like lose sleep over it. So for those, I do want to make sure I'm not like going way out when I'm finding my working length, but I'm more conservative with placing sealer, and I try really hard to only place sealer in like the coronal third, and then when I'm drawing my gutta percha cone in, I'm relying on that, the physics of hydrodynamics to just move the sealer along, and I'm not looking for fireworks on a case like that. I'm looking for a cone that's just conservatively coated with sealer and nothing outside of the root. So with the mental and mandibular canals, more so the obturation is what I change, not the actual instrumentation.
Great.
Any other questions?
Hi, Karen. Can I ask a question?
Hey, how's it going?
Good, good. I got a two-part question. First is, do you ever modify the matrix, like the part that sticks into the access? Do you ever kind of thin it out with a burr to, like let's say like on a lower central incisor?
I have not. I know people who have, but like I showed in that video with Dr. Mazura, if you just block out the canal, you don't need to really do that. You can just build the sound seal up, because the matrix just has to seat into sound seal and just has to not block you out. So if you use a little space maintainer, like I use the micro cannula tip, or you can use a little thin gutta percha, as long as you have fluid flow, you can clean the canal.
Okay, so
But
then
I've heard of people doing that, and I've also heard of people cutting part of the matrix off if it doesn't draw with the rubber dam clamp. Like if the rubber dam clamp moves and mesially and like impinges, your ability to draw the matrix out. I've heard people shave off part of the matrix, and so when they seat it on the occlusal table, they don't have to worry about it hitting the bow of the rubber dam. But I have never had to do that because I try really hard early on to prevent those problems from happening before they happen.
Okay, thank you. And then with the older PIs, the recommendation when you're doing the platform is always to put the matrix, at least touching the cusp tip or the incisal edge, because I seem to remember somebody talking about keeping the thickness of the sound seal thinner because it can dampen the effect of the sound energy activation. Is that a concern still with the new CleanFlow or not really anymore?
I don't know the answer to that question. I rarely have my matrix touching my cusps. I usually have at least a
Okay.
millimeter of sound seal between my PI and my two structure. But Wendy, do you have an answer for that?
No, but I do hear that a lot. It is a good question. Some people feel like the force of the device needs to be as close to the access as possible. So it's a good question that I can, talk to our engineers about. Does it matter if the sound seal is so thick or thin? Will it change the mechanism of action? I don't believe so.
I mean, we're talking like moving the needle when you compare, a traditional endo to a gentle wave endo and how dramatically more debrided that canal is. Like, we're talking about maybe moving the needle a very small percentage. I mean, but I think it's a great question, and I think it'd be interesting to look at the physics of that. With the old PI, the impingement plate was deep inside the access, but now with the CleanFlow, it's all up here, and so it may affect. That'd be a really good study, but I don't know. I don't know if any research is being done on that in the universities right now, but that'd be a really good resident study.
Yeah.
Have to be like a benchtop study, of course, but it would be interesting.
I get some calls and concerns that people find they have to use a lot of sound seal, even describing like 2 tubes for an anterior tooth. You want to comment on that? Or do you find like you're using a lot? It didn't look like it in your pictures.
No, I don't know what they're doing, but that's not, no. I get about 2.5 to 3 teeth per tube of sound seal, typically. At least that's what my assistants tell me. I don't keep track of it, but one time I asked them and I'm like, how often do we change out tubes? And they're like, oh, it's like every 2 to 3 cases. So no, I don't. I think they should probably like do an in-office visit if that's the case, because that seems very expensive. I don't want to pay that much for each case, because that's like, I don't know how much it is per tube, but that's a lot of material. So maybe they're doing it and it's failing and they have to pull it off and start over. I don't know. They're maybe not getting it dry enough, because I feel like moisture is the #1 reason why when I do have a problem with my platform, why I have to jump ship and reboot a little bit.
What tips are you using for the sound seal?
I have two tubes of sound seal on my tray that I'm ready to go. I have one that has the MAC tip by Ultradent that's like kind of opaquish clear, and I have one with the mini tip that's black. Occasionally I ask my assistants for a tiny little composite tip, and those would be for very isolated situations where I need something really, really fine-tuned. But typically on the anteriors and premolars, I start with the black mini tip and I do my initial kind of cingulum. I think you could see them both in my video. And then I switch when I'm ready to do a more bulk of sound seal. I switch to the MAC tip. It's just faster and I don't have to work as hard on my fingers, trying to save the money makers for a few more years.
Stephen, do you have another question?
Oh, okay. I'm still live here. Well, if I was making a face or something, I was just thinking about I've gotten away from BC Sealer for a few reasons, but I really like to down pack my cases, and the heat it getting all gunked up and setting on me because I was doing like single cone for a while, and I just felt like the anatomy. I'd get all these. I'd see a lot of I see a lot of cool anatomy, but I just felt like it's still just got a perch point in a sea of sealer, and so I just have maybe it's not a well founded, but I have this desire to just pack my cases again deep with heat, and so I've gone back to that. So I didn't know if since you seem like you're having good track record and experience with it. Are you deep down packing your cases, or are you just searing at the orifice, which I have.
So my cases, it depends highly on the natural architecture of the canal. So if the canal's big, I downpack as far down as I can go and I backfill. If it's a small, very conservatively sized, like if it's a calcified canal and it's basically ending the size of my last file, which is a 20 slim shaper, then many times my orifice is too small to downpack very far. I'll maybe go 1 millimeter or 2 millimeters at the most, because I physically, even with a tiny heated plugger, I just can't get any further down. And then I'll condense, and then I'll just backfill that millimeter or 2. That's most of my cases. I would say I never sear just right at unless it's like a tiny MB2 that's like 15 millimeters. And so my file really, like, the width of my file at that orifice is so small, I can barely get a fine cone in there. Then I'll just sear at the orifice and just do a little condense. But most of my canals get at least about 1 millimeter of heat, condense, and backfill.
Okay. Yeah.
What sealer are you using, Steve?
I just went back to H plus because I had a really good track record with it, and it flows good enough. I it's hard to measure, but I just feel like I have a good track record with it. So
no, I use that for like I don't know, 12 years or something. It's great.
Yeah. But but if you're doing those deep cases, the reason I asked that initially was, and one of the reasons I got away from it was when you are doing bigger canals or multiple cones, it sets up when you hit it with heat, right? So if you got a lot of sealer in there, it's like the sealer was kind of like gunking up as
like chalky.
I think it just sets it, doesn't it? Set it like heat. Doesn't the heat set the sealer, or not necessarily?
I feel like maybe it's just kind of like chalky, like it's a little like maybe it's kind of partially set. I don't know. I haven't
issue for you. Yeah.
I don't have a big issue with it. I mean, maybe sometimes I take an Explorer and I kind of clean a little bit of it. I don't know. Or maybe I add a little more sealer, because you know how when you take putty and you add sealer to it, the putty goes to a lower bodied. So, I think maybe I just add a little more sealer and then backfill, and I just condense with my gutta percha. And
if you were doing a big backfill though, and you stuck the Obtura or whatever your heat backfill device is, the heat from the tip of the backfill into a sea of sealer, I think that's where it would like start setting up, and it wouldn't just like flow out nicely, but I don't know. Maybe I just didn't like what I was seeing, but it's not really a clinical issue,
Yeah. Interesting.
Karen, what do you think of this? I get a lot of questions of, Wendy, I'm not getting the anatomy that I'm seeing on Instagram. And I will talk to them about what sealer they're using, how they're drying. But recently, I've been noticing the smaller shapes are what's creating the anatomy. Have you found that? Like you just said, you're doing slim shapers.
Yeah. Anatomy is pretty, but it shouldn't be what we're all like striving for per se, because while it's pretty, it really doesn't mean success or failure, right? So yeah, I've had cases that I was blown away I've had cases that I was wanting more anatomy and they still healed. Like, it doesn't necessarily mean anything except it's just fun, right? So, the reason I use slip shapers is I just truly believe that the mechanism of action of gentle wave works. And why should I remove any more dentin than I have to? Like, I don't even use an orifice opener anymore. I just use the Slim Shaper 15 or maybe it's a 17 and 20. And I would only use the one if I could obturate that small, but I can't. I've tried it. I just can't get my cone. They buckle, my cones buckle. So, I don't know. I mean, I don't instrument big anymore, so I can't give you feedback on that. But some cases I have cool anatomy, other cases they just look like normal root canals that are just skinny. So I don't know.
Okay.
Ultimately, I believe, and I learned it the first week of residency, it's what you take out, not what you put in. So that's still how I believe it to be true.
Great.
Any other questions?
Any bit more? Anyone? How about one more?
Any questions on the chat? Did we answer everything?
I think we're pretty good. All right. Well, thank you, everyone. Please join us for our next Gentle Wave Study Club. This is going to be on August 28th. Normally, our webinars are on the third Wednesday of every month, but due to some summer scheduling, we have moved it to the last Wednesday of August. This webinar is going to be called Ask the Experts. It's going to be very interactive and engaging. We invite you to submit your questions when you sign up in the registration. There will be an area for that. And we're going to start tailoring this study club to your submitted questions. So please try and join that call. It's going to be quite the night. Please visit gentlewave.com to learn more about any of our hands-on courses or peer-to-peer education near you. And then I'd like to thank everyone once again, especially Karen. She's a friend, a colleague. So fun to see you. Your energy is fantastic. It was so informative, exactly what we were asking for. So thanks for that. And everyone go enjoy your night.
Thanks for having me, everybody.
Okay, thanks, Karen.
Have a good one, guys.
Thanks so much.